Hello, everyone who's logged on so far. We're just giving it a couple more minutes for any other attendees still filtering in, and then we'll get started shortly. Okay, let's go ahead and get started. Welcome everyone to the SSAT webinar for preparing for the certifying exams, aka the mock oral webinar. We're giving this webinar on behalf of the Resident and Fellows Education Committee for the SSAT. I am one of your moderators. My name is Rachel Kim. I'm one of the general surgery residents at Indiana University, and Carlos is one of my co-moderators. Do you want to introduce yourself, Carlos?
Yeah, hi everyone. Thanks for joining. Like Rachel said, I'm Carlos. Did my training at Stanford, but I'm currently a surgical oncology fellow at Moffitt Cancer Center in Florida. Thanks for joining again.
We're really excited to have everyone on. We have a really amazing cohort of both faculty examiners as well as trainees who have graciously agreed to or volunteered to be examinees. Hopefully this can be just an educational and resource for everyone as well. This webinar will be recorded and available at the SSAT website. Oops. And if you have registered, please look for an email when the webinar recording is available online. It will also be posted to the SSAT YouTube channel, as are many of our prior podcast, our websites, webinars and podcasts as well. And then you can also listen to the webinar as a podcast on the SSAT Soundbites podcast series for surgeons. If you're not already, this webinar is free for anyone who registered, and all of our resident and fellows education webinars are free as well. But if you are not already a member of the SSAT, I highly recommend that you join. This is the fee for the active members. But for this webinar, a lot of our, I'm sure a lot of our attendees for this webinar are trainees, either medical students, residents, or fellows. For trainees, a candidate membership is only $20 per year, and so it's very affordable, and for and the same fee for medical students as well. Benefits include a subscription to the Journal of Gastrointestinal Surgery, early bird registration to DDW, and lots more that you can find more information on our website. And so, like I said, we have a really fantastic cohort of scenario examiners and examinees to give you a wide breadth of scenarios. These are the topics that will be covered today. Obviously, for the true oral boards, the topics are not just limited to this, but we just wanted to give you a general sample with the greatest variety, I think, in the core topics that we think will be included in the certifying exam. So we'll get started with Dr. Tanya Rinderknecht from UC Davis. She will be starting with a trauma and critical care scenario. So let me unshare my screen.
Well, Rachel does that just as a housekeeping. We will be leaving questions for the end of the webinar. So if all of you watching have any questions, write them down. You can bring them back at the end. We'll run through all the scenarios first.
Okay. And so the rest of us will, so that we can focus on the scenario, the rest of us will be blacking out our cameras, but we'll go ahead and get started with Dr. Rinder Connect and Dr. Lindsay Hopper, who will be her examinee.
Okay, hello everyone. We are starting with a 63-year-old male who is brought in by ambulance to the emergency department after a high-speed motor vehicle collision. The paramedics tell you that they have been unable to get IV access because he is confused and combative. They've given him a GCS of 13. His heart rate per them is 120. His blood pressure they have taken at 95/50. And his oxygen saturation is 92%. How would you like to proceed?
So as he comes into the trauma bay, I would, while we're working through our primary survey, be having some of our nursing staff assist us with getting IV access. And so what is his primary survey for our findings?
His airway is patent. He has bilateral breath sounds, but he has tachypnic in the 30s. He is tachycardic as advertised, and your first palpated pressure in the trauma bay is 88.
Okay. At that point, so I'm sorry, you said that he had bilateral breath sounds present? Okay. Then I would activate massive transfusion protocol with 1:1:1 transfusion.
What is one of what?
One RBC to one FFP to 1 6-pack of platelets after 6 units of the RBCs and FFP are given.
Okay, so you have one IV. What would you like the nurse to put through it first?
1 unit of RBCs.
Okay, that's going.
And then be working on having 1 of FFP ready afterwards. And so once the blood has started, we reassess his vitals. And what is his blood pressure at this point?
His blood pressure is still in the high 80s. He's still tachycardic to the 120s. He's combative. He's fighting off the examiner. You notice that as he's fighting, he has some abrasions on his left side and on his head.
On his left side of his chest?
Chest and abdomen.
Okay. And have we been able to get additional access yet?
Yeah, you have 2 18s now, peripherals.
Okay. I would continue transfusing blood products. And then we haven't had any improvement in his blood pressure still in the 80s.
It's 91 now.
Okay. So I would have our staff do a fast exam to assess for any intra-abdominal fluid collections.
Okay. You see free fluid in the left and right upper quadrants as well as the pelvis, but there is no pericardial effusion.
Okay. So since he's hypotensive with a positive fast exam, I would want to proceed to the operating room for an exploratory laparotomy.
Okay. Is there anything else you want to get before you leave the trauma bay?
We have access. And you said that he had breath sounds, but he has tachypnic, so I would probably get a chest x-ray as well.
Okay, you get a chest x-ray and both lungs are up, but you do see a hemothorax on the left side.
Okay, then I would place a left-sided chest tube.
Okay, you get about 500 cc's of blood out and his vitals stay the same.
Okay, so I would then proceed up to the operating room.
Okay, tell me what you're going to do in the operating room.
So I would have him supine and drape him in trauma drape. So from sternum to mid-thigh with trauma draping, and proceed with performing a exploratory laparotomy.
Okay. You open the abdomen and you find a bunch of blood.
Okay. Then I would evacuate clots by hand and then try and start packing in all 4 quadrants and see if we can reassess with having ongoing anesthesia, performing ongoing transfusion.
Okay, so you get all 4 quadrants packed. You take the lap pads out serially and you find most of the blood and fresh clot is in the left upper quadrant around what appears to be a shattered spleen.
Okay. At that point, what are his vitals at this point?
Anesthesia is actively resuscitating, and his heart rate's in the hundreds, and his blood pressure is about 100.
Okay. So I would proceed with a splenectomy at this point in time.
Okay. How do you do a splenectomy?
So I would take down the splenic attachments or the ligaments, splenic ligaments bluntly to be able to medialize the spleen, and then palpate where the pedicle is, or the splenic hilum, and try to clamp across the artery and vein separately, and then transect those above the clamps and suture ligate the artery and vein separately.
Okay. Is there anything else you need to do to get your spleen out?
What did I miss?
Your spleen's out.
Okay.
The patient is doing better. Good job. Change in scenario. You open the abdomen, you find a bunch of blood, you take out all your packs, and you find not only a shattered spleen, but also multiple bleeding liver lacerations, as well as a small bowel perforation with succus in the abdomen.
Okay. I would, if his blood pressure was still in the 100s at this point in time, systolics in the 100s.
Sure.
Okay. So I would first try and proceed with doing a bowel resection to get control of any contamination, and do a stapled anastomosis, or a stapled resection.
So you do your resection, and you notice that the edges of the bowel are bleeding, and your liver laceration is oozing, and your anesthesiologist tells you that they're having a hard time keeping the patient's pressures over 80, even with ongoing transfusion. And his temperature is now 35.5.
Okay. At that point, I would ensure that there are packs over the liver to try and get some hemostasis, and then place a temporary abdominal dressing so that we can get the patient back to the ICU for further resuscitation and warming.
Okay. So when you arrive in the ICU, what are you going to tell the ICU resident to do?
So he would need, or they would need to trim the labs, and then I would recommend keeping the patient on with a bear hugger, running warm fluids, trending ABGs to evaluate for base excess, as well as lactic acid acidosis, and monitoring the pulse pressure to determine how the resuscitation is going.
Okay. And when would you feel comfortable going back to the operating room?
Once the patient appears to have been appropriately resuscitated and at a normal temperature, then I would proceed back to the operating room, but usually give them 24 to 48 hours to be resuscitated.
Okay. And you go back to the operating room 24 hours later. Things look better. He's warmer. He's less coagulopathic. You see 2 large liver lacerations with not much bleeding anymore, but there is some bile staining, some pooling bile, not a lot, but some. And you see your 2 stapled small bowel ends. So what are you going to do?
So I would do a further inspection of the liver lacerations, attempting to clip any draining bile ducts that are present, and get control of any bleeding with either direct pressure or hemostatic agents. And are we able to get hemostasis with the liver laceration?
Yeah, they're pretty hemostatic.
Okay. And is the patient still on any pressors at this point in time?
No.
Okay. And they're more stable from a hemodynamic standpoint?
Yes.
Okay. Then I would proceed with a bowel anastomosis if they are stable.
Okay. Are you gonna close the abdomen?
I would, if they are no longer on pressors and remain hemodynamically stable, I think that it would be safe to close the abdomen at that point in time.
Anything you want to do for the liver lacerations before you close?
Re-examine to make sure that they have ongoing hemostasis after our interventions.
Okay. Okay. You close the abdomen. Patient goes back to the ICU. Has a long ileus, otherwise does okay. spikes of fever on post-op day 7.
Okay.
We're done.
All right, thank you very much. Do you want to discuss or debrief some educational points from that scenario, Dr. Rinder-Knecht?
Sure. So I think for trauma critical care cases, as with other cases, the goal is to move through the case. So being given new scenarios or new things to deal with is not, doesn't mean you've done anything wrong. It just means we're trying to get to as many different ways to evaluate your knowledge and your decision-making as possible. So Dr. Monsino did a good job of getting through her primary survey and being decisive about going to the operating room. A hypotensive blunt trauma patient with a positive FAST should be heading to the operating room. How much time the examiner spends asking you about other things in what you want to do in the ED is going to be variable. They want to see that you can make the decision, go to the operating room and do an operation. The change in case scenario from a somewhat stable patient to a patient who remains unstable and becomes coagulopathic and cold is, I would say, pretty common, and you need to know when it's time to not be in the operating room anymore. That's kind of where the case scenarios can transition a little bit from operative trauma management to critical care. So I think massive transfusion is fair game. The importance of warming, avoiding coagulopathy, acidosis is fair game. I certainly had an open abdomen on my oral boards. So I think those are all reasonable questions. And then if you have extra time, you're going to start getting asked about complications from your operation, even if everything you said was correct. So we got cut off right before we were going to manage our abscesses from a bile leak, but they will keep going until the time is up. So I think those are my comments.
And I think that's perfectly on time since we're at 10 minutes. Awesome. Next up, we have, I believe it's Dr. Betty Fan from the University of Chicago, who will be doing the breast case scenario with Dr. Chavi Rihani, who will be doing a double header also with colorectal. So I'll pass it on to you.
All right. Okay, Dr. Rouhani, thanks for volunteering. So you are in clinic and you have a 60-year-old female who's referred from her PCP for an abnormal screening mammogram. It showed some suspicious calcifications in the right breast, and so she's there to see you for further steps.
Okay. So in this 60-year-old patient with new findings on a screening mammogram, I would start with a comprehensive history and physical, making sure that I'm asking about any risk factors for any breast cancer, which is something I'm concerned about with a patient in this age group presenting as she's presenting. Asking about age menarche, any pregnancies, how long she breastfed, as well as any pertinent family history of any cancers, making sure that I'm asking about the age at diagnosis of those family members as well. And then my physical exam at the end.
So she has so to start out, she has no relevant past medical or surgical history. She has no kids. Her first menstrual cycle was at 12. And she has family history of a mother with breast cancer at age 45, but otherwise no other relevant history in her family.
Okay. I would also, as part of my history taking, ask her about any symptoms that she might be having associated with her breasts on either side.
No symptoms whatsoever.
Okay. I would move on then to my physical exam, paying particular attention to, of course, the breast exam bilaterally, as well as the axilla on both sides. And the lymph nodes cervically, supraclavicular, and of course in the axilla.
Okay, so you perform your breast exam and it is unremarkable. There are no masses or skin lesions, no nipple discharge. She notes she's a C cup.
Okay. So at this point, based on the information that I have, her age and some of her family history with having a mother who did have breast cancer at the age of 45, which is pretty young, my suspicion for breast cancer is pretty high at this point. I would talk to her about next steps, which would include a biopsy of the suspected area of calcifications.
Anything else you want before the biopsy? She's only had a screening mammogram so far.
Yes, I would start with a diagnostic mammogram and also get an ultrasound just to see if there's any more obvious masses on the ultrasounds.
Okay, so she gets a diagnostic mammogram and they see a 1 centimeter span of suspicious calcifications. They do not see an ultrasound correlate, and they ask you how you want to have this biopsied.
I would ask our radiology colleagues to do a stereotactic core biopsy of the area.
Okay, so they do the biopsy and it comes back as ductal carcinoma in situ. It's a grade 1 ER positive. Patient comes back with this pathology report to review what you recommend for her.
Okay. So at this point, I would discuss her options with her and recommend an excisional biopsy of the affected area and discuss with her, the risks of upstaging with DCIS. Because on my physical exam, I wasn't able to, I guess, palpate anything. Is that correct?
Correct. You did not palpate anything for this DCIS.
Okay. So I would also discuss with her that before we do any surgery, our next step would be a mag seed placement so that we could actually proceed with excision.
And the surgery that you want to do is a excisional biopsy?
Yes, ma'am.
Okay. Are there any other options to treat her DCIS?
We could proceed with radiation or just watch and wait if she was really hesitant to do any other procedures. But with the risk of upstaging to invasive cancer, I would recommend the excisional biopsy.
Okay, so then you do your excisional biopsy under MAG-seed and the final pathology comes back with an invasive ductal carcinoma. It measures 1 centimeters and your margins were all negative. It was a grade 2 and it's an ER positive, PR positive, HER2 negative cancer. So she comes back and asks you then, does she need any more surgery?
Yes. So unfortunately, in this patient, we did have an upstaging from the DCIS to invasive cancer. I would discuss with her that thankfully the margins are negative, but because it's invasive cancer, we would have to go back and proceed with a sentinel lymph node biopsy to rule out any metastasis to lymph nodes in the axilla specifically. She would also need, radio tracer and dye at that time to allow for the sentinel lymph node biopsy.
How do you do a sentinel lymph node biopsy? Can you walk me through it?
Yeah. So I would start that morning. Our radiology colleagues would have done the radio tracer injection. I would perform the blue dye injection in the OR. A couple milliliters of diluted methylene blue is what I would use. I would inject it subareolar. And then once that has had time to distribute throughout the lymphatic drainage system, I would make my incision in the affected axilla, kind of a C, upside down C incision, right below the axillary hairline, making sure that, if I did end up for any reason having to proceed with an axillary lymph node dissection, that incision would be incorporated in any lengthening I may have to do. And then using a gamma probe, I would find where my highest point of signal was, and I would excise that lymph node. I would get an ex vivo count of that lymph node, and then proceed with excision of any sites that seem to have more than 10% of that radio tracer count. And of course, I'd be during this time tracking if the nodes are hot and blue or hot or just cold and blue. hoping to get as many lymph nodes as I could find, at least 3, but whatever I can find.
Okay, and she has 1 of 2 lymph nodes positive. It was a 3 mm metastasis with no extranodal extension. Do you recommend an axillary dissection with this positive lymph node?
I would not at this time because it's only 1 lymph node. Since she had breast conservation therapy for this, I would allow her just to continue with radiation. I would have referred her to Med-Onc and go from there.
Okay, thank you.
Okay, would you like to debrief or have any general discussion feedback topics for the scenario?
Yeah, so great job overall. I think some things that, for the breast scenarios, one, they're always going to be fairly straightforward because there's a lot of debate in some of these areas. So it's going to be a really relatively straightforward scenario for the most part. I think a couple of things that I would kind of keep in mind is family history. So, patients who are younger get diagnosed with family history of breast cancer, genetic testing is a big thing just to kind of help clarify their overall risk. I think, just knowing the nomenclature for excisional biopsy versus lumpectomy versus mastectomy. So, she had a DCIS, which we technically kind of treat like like a cancer. So she would have gotten a lumpectomy, which, we're looking for margins and everything. Again, she doesn't need this, but, giving patients the option for mastectomies as an alternative to, a lumpectomy with radiation, probably could have been discussed a little bit. But otherwise, I think you hit on, all the safe, points and everything. You got a needle biopsy, which is always standard of care now for any breast abnormalities. You kind of talked about needing to localize it, since you can't palpate it. So good job.
Thank you.
All right, and then with that, we'll move on to our next scenario. Dr. Rahani will continue to be our examinee, and Dr. Mark Zhao from UCSF will be our next examiner on colorectal.
All right, stay in the hot seat here. Okay, so your patient is a 65-year-old female with a past medical history significant for diabetes and hypertension. She presents to your clinic after she was found to have a positive stool DNA test. She has no family history of IBD or colorectal cancer. The rest of her history is non-contributory. On exam, her abdomen is soft. She's not distended. The rest of her exam is non-contributory. What would you like to do at this point?
Okay, so for this 65-year-old female with a positive fecal occult blood test, I would start with my thorough history and physical, which I think you kind of already covered most of the points that I would be asking about. I would also be asking if she's having any symptoms other than just if she's having any abdominal pain, if she's having any rectal bleeding, or any unintentional weight loss or things like that.
No rectal bleeding, no obstructive symptoms, no abdominal pain. She is essentially asymptomatic.
Okay. When was her last colonoscopy?
She's never had a colonoscopy.
Okay. So I would discuss with her that for someone with her presentation, our first step would be a colonoscopy. I would order a bowel prep and get her set up for the colonoscopy.
Okay. Would you like to do the colonoscopy yourself, or would you have someone else do it?
I would like to do the colonoscopy myself.
Perfect. So you do the colonoscopy. The colonoscopy unfortunately reveals a 4-centimeter malignant appearing mass in the ascending colon. And when you are doing the biopsy, when you are doing the colonoscopy, you biopsy the lesion and you tattoo it distally.
Okay.
The pathology results reveal a moderately differentiated adenocarcinoma. She is now back in your clinic to discuss next steps.
Okay. So at this point, we would have a discussion about what this diagnosis of adenocarcinoma means for her, and what the next steps are. First, we would proceed with staging and make sure that there's no metastasis. So I would let her know that the first steps are going to be some scans coming up. She'll also need some blood work, including basic labs.
What kind of scans?
A CT abdomen, pelvis, and chest with contrast.
Okay. So you get that the CT chest, abdomen, pelvis reveals no metastatic disease. You also get a CEA, which is 5.8. She's back in your clinic now. Now what?
Okay. So at this point, I don't have any evidence of metastatic disease. So her next step would be proceeding to surgery. And I would talk her through the fact that what we're planning would be a right-sided hemicolectomy
Would you do
with
this open or
anastomosis.
laparoscopic?
Sorry, say that one more time.
Open or laparoscopic?
I would do it robotically because
Okay.
that's what I've done so far, but it would be laparoscopic. I would proceed minimally invasively.
Okay. How would you do it robotically?
So the patient would be positioned supine. I would put my ports in. I would have 3 ports. The first camera port would be slightly to the left of midline, and then my other 2 ports would be in the left upper and left lower quadrant. I would start again just laparoscopically, making sure that there's no evidence of metastatic disease that was occult and missed on the scans. And if that is found to be the case, I would then proceed with the surgery. While I'm still laparoscopic, I would retract the omentum cephalad, position my bowel so that it is out of the way and on the left side, and that my right colon, my mesocolon are easily visible. The patient would be in Trendelenburg and left lateral decubitus position. I'd duck my robot. And then I would start with a medial to lateral approach, starting with identifying my ileocolic pedicle.
Okay.
So
you're doing that, you're mobilizing the colon, you can't find the tattoo.
okay. I would start with mobilizing my colon, kind of turning it, retracting it more medial to see if further mobilization along the white line would allow me to better visualize it.
Okay, so you find the tattoo, you perform the resection, and you make an anastomosis. She gets out of the hospital in 3 days. The pathologist calls you and says that this is a moderately differentiated adenocarcinoma of no LBI. It invades the serosa, 0 out of 10 lymph nodes. What would you characterize the stage of this tumor?
If it's invading the serosa, but not into any other like adjacent structures.
Correct.
Is that right?
That's correct.
So that would be a stage 3 or 4 tumor.
Okay, so the pathologist is grading it as a PT3NX. The patient's in your clinic now. She asks, what's the next step? Do I need chemotherapy?
Okay, since it is PT3, she would be a candidate for adjuvant therapy. And she would be referred to med-onc for setting that up.
Okay. Is there any other reason why she would need adjuvant therapy?
If she had gotten less than 12 lymph nodes in her lymph node harvest, based on the specimen, that isn't the case, but if she had, that would be the other reason. Or I guess if she was much older, and if any of the pathology showed that she was, a very high risk tumor.
Okay. All right. That's the end of the scenario. Good work. So just a couple of things. I think you did a good job overall. I would just say we need to just tighten up the presentation a little bit for the description of the colectomy. I think a good rule of thumb is if you can describe a operation in 5 or 6 steps. That's it. You don't need to talk about where the ports go. Those things I think it will just take too much time, and 5 to 6 steps, less than a minute to describe operations. And I think every single operation on the score list of operations you need to know that you can do in 6 steps, even a Whipple.
Okay.
They're gonna throw curveballs at you. At least that was my experience on the test. So the curveball is you can't find the tattoo, or curveball is, there was actually less than 12 lymph nodes. There was only 10 lymph nodes.
Oh, I misunderstood that.
Yeah. And then another one is intraoperative bleeding, or the right colon. It's the duodenum that gets in the way. Colorectal is pretty simple. Right colons, it's the duodenum you're scared of. The left colon, it's the ureter you're scared of. So, those things you just want to mention in passing too, like as part of your description of the procedure. You're going to protect the duodenum, or you're going to protect the ureter.
Okay.
One thing I do want to mention is very colorectal specific, but anytime you get a colorectal cancer, you should ask about microsatellite instability, because that does now change how we manage them. And then very briefly, indications for chemotherapy. So she is, she's kind of in the gray area. This is not really a fair question. She's probably considered a stage 2. She's T3. And she's NX because we didn't get enough lymph node yield. But common indications for chemo in stage 2 patients are T4 patients, or patients with less than 12 lymph nodes, which is her. Perforated or obstructed cancers, or poorly differentiated, or if there's lymphovascular invasion, or if there's tumor budding. That's another relative indication too. Just overall for the exam, I know we have to move on, but for any cancer, I think a good rule of thumb is just to think about naming it, staging it, and then treating it. And then what I did for the exam is for the major cancers, I just went through the NCCN guidelines, and it's pretty nifty that you can just move on from one stage to another in the algorithm. And then really just, it was easier said than done, but have a really short memory, and you have to move on from the last scenario, because each scenario it gets reset. So don't think about what you said 2 minutes before. Try not to, and just keep answering the question ahead in front of you. And then what really caught me off guard in my exam was that we've always been told that they give you a lot of information on the opening prompt, but my examiners actually gave me really little information. So just be aware that there's some variability in how long the prompts are. And then they went from one scenario to another like immediately. There wasn't a word that they used to say, okay, I'm moving on to the next scenario now. It just went from one scenario and then immediately to another one. So that caught me off guard too. But that's all I have. Good job.
Thank you.
Okay, awesome. Then we'll be moving on to our next presenters, the HPV section. It would be Dr. Monica Dua from Stanford University, and she is going to be doing the case scenario with Dr. Rejoice Fari Gongoni. I'll pass it on to both of you.
Great, thank you, Carlos.
All right.
All right, I see that you're on, so why don't we go ahead and get started?
Okay.
Make sure we have a timer too. All right. A 72-year-old male is brought into the emergency room by his daughter for ongoing fever and chills, despite trying Tylenol at home. He is usually quite active and only has mild hypertension and diabetes. Recently, he has been very fatigued with poor appetite. On quick exam, he is noticed to be jaundiced. How would you proceed?
I would want to investigate the appetite, any nausea, vomiting, any changes in bowel habits, and then any changes in the color of his stools.
He does say that his stool appears to be a little bit lighter over the past week, in the urine as well, a little bit darker. He is able to tolerate food, so he doesn't have nausea or vomiting, just the appetite and amount that he's eating is quite low.
Okay, any abdominal pain and any weight loss?
No abdominal pain, but the family, the daughter says it's been about 8 to 10 pounds in the last month.
Okay, all right. Then I'd like to know any other pertinent medical history other than the hypertension, diabetes, any prior surgical history.
No past surgical history. The past medical was just the hypertension and the diabetes.
Okay, and then social history, any smoking and substance use.
No substance use. He did smoke for 10 years earlier on in his life, but has since quit.
Okay. I'd like to move on to vital signs as well as the physical exam.
Sure. In the ER, his temperature is 101, blood pressure is 90/60, heart rate is 112, respirations are 14, and he's satting well. He looks a little bit cachectic. He does have some scleral icterus. His abdomen is otherwise soft, and he's not peritoneal. He has some lower extremity edema.
Okay. So at this point, I'm worried, that since he's not tender, that this looks like his painless jaundice. And given his vital signs, I'm worried that potentially this could be cholangitis. So I would at least want to start off with resuscitation with 30 cc per kg bolus. And then I would want to obtain labs, namely a CMP, a CBC, coags, and potentially tumor markers as well.
Okay, the bolus goes in and he goes from the 90/60 to about 110/80. He does get labs drawn, and this comes back with a white count of 20, hematocrit of 42, creatinine of 1.6, and bilirubin of 18, INR 1.2. The tumor markers are going to take a little bit longer.
Yeah, okay. At this point, I'm really worried about him being cholangitic, even though he's responded. And so given the hyperbilirubinemia, I'm really worried that this either benign or malignant, but leaning more towards a malignant etiology, given the weight loss. And so I'd consult GI for ERCP and potentially an EUS to see if there's a tumor in the pancreas or in the distal common bile duct.
Okay.
And I would also start him on antibiotics. Sorry, forgot to mention that.
What antibiotics are you using?
So broad spectrum antibiotics could be Zosyn.
The ERCP is done and it shows narrowing of the distal bile duct. They do a sphincterotomy and they place a stent. Initially, there is some purulence mixed with the bile, but by the end of the case, there is pure flow of bile. They are able to do an EUS since he's stable, and this does show a mass in the head of the pancreas with some vascular involvement of the portal vein.
Okay. Do they perform a biopsy off the mass?
Yes.
Okay.
And that does eventually confirm pancreatic adenocarcinoma.
Okay. So at this point, I think I would initially want to focus on treating the cholangitis, making sure that his labs normalize. But I would want to also perform staging with CT abdomen pelvis, preferably pancreatic protocol once the creatinine is normalized. And then I'd also want to get a CT chest.
The chest is clear. There's no evidence of metastatic disease. The abdomen pelvis shows normal pneumobilia after the stent placement. There is a hypodense mass at the head of the pancreas measuring about 2.3 centimeters and 180-degree involvement of the portal vein. There is no SMA involvement. Okay. What would you talk to the patient about at this time?
Yeah, so I inform him that he has a borderline resectable tumor and would likely be a candidate for a Whipple operation, but I would want him to get stronger, improve his appetite, and refer him to med-onc for neoadjuvant chemotherapy.
He gets set up with med-onc and completes 4 cycles of chemotherapy. There is good response in the tumor markers that you ordered with some decrease from 500 to 83. The repeat CT scan shows a decreased size of the mass, and the oncologist now sends him back to your clinic.
Okay. Given the good response at this point, I would make sure the patient is fit for surgery. And if that is the case, then I would consent and add them on for a Whipple.
Great. Can you tell me the steps of a Whipple?
I'd start off with a staging laparoscopy to ensure that there are no peritoneal disease. If there's no peritoneal disease, I would do an open Whipple, so upper midline laparotomy. I would mobilize the duodenum by a Coca maneuver, enter the lesser sac, and try to mobilize the pancreas off of the mesocolon. And then, given that this was a borderline resectable tumor, I'd probably forego the retropancreatic tunnel. And then I would divide the GDA and then perform a cholecystectomy, divide the bile ducts proximal to the cystic duct. And then I would divide the stomach at the antrum for a classic Whipple, divide the jejunum as well. And then after this, I would sort of mobilize the rest of the pancreas off of the SMV and the SMA. And then prior to dividing the pancreas, I would make sure that I have control of the portal vein and the SMV, as well as the splenic vein. And try to dissect the pancreas off of the SMV as much as possible up until the point where the tumor is adherent to the portal vein. I would, since the tumor is involving the splenic vein confluence, I'd probably ligate the splenic vein and then have my vascular surgery colleagues available to help out with the portal vein reconstruction. Hopefully be able to do an end-to-end anastomosis. And then I would divide the portal vein and SMB, and then hopefully I'd be able to do an end-to-end anastomosis.
Okay, and if you found a liver lesion on your diagnostic laparoscopy, what would you do then?
I would biopsy it, send it for frozen. And if it comes back positive, then I would abort. But I would talk with the family member and consent and see if they'd be open to a double bypass with a GJ and an HJ, but no resection.
Great, thank you. So that was 7 minutes. I think the positives that I really liked that you did were a lot of the back and forth. I think a lot of people ask for too many things because you're, you know what to do, right? And so it's a good thing. It's actually a positive thing that you have a lot of wisdom and you know how to do it. And this is how we function in clinical life. We order a bunch of things and we act appropriately. But just like how you did, I liked how you just did a couple things at a time, right? Like you just asked for labs, you just asked for vitals, and then you just asked for EUS, ERCP. It wasn't this whole list, even though you're thinking about it from the front. I think that in the oral board scenario, it is okay for you to actually say what you're thinking. Like, I think this is cholangitis. I am worried about painless jaundice. I think that was great. It keeps us on the same page. So like said, I am worried about painless jaundice very, very quickly in this scenario. Then like a little bit after the vitals, you said, I am worried about cholangitis. Then as soon as we went to, a little bit later on, you're like, I think this is more likely to be a malignancy or a pancreatic mass. And I think that's good. You're not, I don't think it strays you in any dangerous way. I think if anything, it lets the examiner know what you're thinking. And if we're kind of steering you also in the right way. Just like the other examiner said, I think your Whipple explanation was a little bit long.
I wasn't sure.
We're like over a minute for the Whipple explanation, like you don't need to say upper midline cochlearization, anything like that. Actually, it's probably a good chance for me to just share this real quick. I have that. Let me see if we go here. I just have a couple of tips that apply to like any scenario. I can just go like this. So tips to stay organized in the oral board: listen to the summary statement. Most of the information is there. Like I know Dr. Zhao said that he didn't have a huge intro scenario, but I do think a lot for the scenario can be there. And you did this very well. Summary sentence of things that you're thinking, what you're concerned for, what you're worried about, where you will proceed. You did this part really well. Do not ask for too many things, because sometimes you ask for things and they don't even remember, so they can't give it back to you. They'll only give you like 2 at a time. And I like this, that you organize what you're asking for into groups. So when you first got the scenario, you're thinking about a little bit of past medical history and ruling out, malignancy. So you ask questions appropriate to that. Then when you realized it was cholangitis, you asked, you gave a bolus, you did labs, you did white count, antibiotics. That was like the next group. Then the third group of what you were organizing was staging, right? Like ERCP, EUS, biopsy, and CT. So I think those are good. You kind of like, did it in little groups. I think it's important to also analyze what the examiner gives to you. So like make sure you don't just brush over what they give you and ask another thing. Sometimes that also helps in terms of keeping you on target. And then especially, I didn't give you too much scenario switches, but I think like when you have a scenario switch, it's good to like reset your mind. Like, okay, we have a scenario switch, and you can also say like how you were doing, like, okay, now I'm worried about this. Okay, now this scenario is taking me to think about this, right? And that helps kind of organize your thoughts. And just like we all say, write out complex operations in 4 to 5 lines. So let me see. So this is here, I'm going to skip to one thing here. So for example, these are what I mean by I wrote out for the oral boards, like for Ivor-Lewis, you can just say Ivor-Lewis is performed in 2 compartments: abdominal portion, cochlearization, creation of the gastric conduit, preserve the right gastroepiphilic arcade, pyloroplasty, and feeding tube. Then the abdomen is closed, and the thoracic portion is through the right chest with gastric pull-up for the distal esophageal anastomosis and lymph node dissection, and a chest tube is placed. That's it. 4 or 5 sentences. Nissen can be done laparoscopically. Short gastrics need to be taken. Both right and left crucis are mobilized circumferentially around the esophagus. Identify, preserve the vagus nerve branches. After good length, put a bougie or endoscope in and make a loose wrap of the fundus 360 degrees around the esophagus. You know, same for a Whipple. I got Whipple on mine and I'm an HPV surgeon. I honestly, Pari, was very, very proud of you because you've been on service, and I was like, oh, you have the Whipple down in your head. But you don't need to do that. You can just say a Whipple is done in two parts. There's a resection and a reconstruction. The resection involves, you know, cholecystectomy, distal stomach, duodenum, and dividing the pancreas over the portal vein. The reconstruction is done in this order. I tend to do a PJ, hepatocogegenostomy, and anticolic GJ, and then I place 2 drains over the most critical anastomosis. If they want to ask you about more things, great, you know, then you have it. But I think they're mostly just trying to get to the point. But this is like something I felt was really helpful for me, is that I wrote out big operations in 4 to 5 sentences. And I think that really helped me move along through scenarios, because you don't want to use too much time during that.
Yeah. Okay. Thank you.
Yeah. Good job.
Thank you so much, Dr. Dua. That was really helpful. I think those slides and those summary points. So we'll move on to the next scenario, will be our pediatric surgery scenario. Dr. Brian Gray will be our examiner from Indiana University, and Dr. Fikram Mesfin will be our examinee as well.
All right, Dr. Mesfin, how are you doing today?
Good, how are you?
Great, let's go ahead with this patient. So you're called to the emergency department to see a 6-week-old infant who is referred in for increasing frequency of emesis. Mother says that over the past few days, the child has been vomiting more and more, and now the child is not as active as she used to be and is not urinating as much.
Okay. The first thing that I would like to ask is, what is the character of the emesis?
What do you mean by character?
Is it bilious, is it bloody, or is it non-bilious?
So there's no blood and there's no bile in the vomit. It just looks like the food the child's been eating.
Okay. With the non-bilious emesis, my concern for malrotation volvulus is low. So then I will continue and ask as far as any number of wet diapers.
What diapers have decreased over the past couple of days?
Okay. And I will also ask any sick contact in the family, any URI symptoms that can or change in feeds that can potentially explain the emesis.
There have been no sick contacts, no other URI type symptoms for the patient, and no change in feed recently. They do breast milk.
Okay. I would like to then move on to physical exam and assess the patient. In the physical exam, I would like to know what his abdominal exam is and what his hydration status looks like.
And how are you going to assess the hydration status?
So if you said that he looks more listless, if there is any decrease in capillary reflex, skin turgor, any wet, is he able to have tears and things like that?
Okay, so the patient has normal vital signs, normal blood pressure, other than slight tachycardia. The child does appear to be slightly pale and lethargic, and the capillary refill is about 3 seconds. You do feel the head and the anterior fontanelle is sunken slightly. Your abdominal exam is normal otherwise.
Okay. At this point, I am considering pyloric stenosis, so I would like to move on and get laboratory values and abdominal ultrasound.
Which laboratory values would you like?
Specifically, I'm looking for his BMP to look at his electrolyte status.
Okay, so you go ahead and order the BMP, and it comes back an hour later with a sodium 128, potassium is 2.8, chloride 85, the bicarb is 40, BUN and creatinine are normal. Did you ask for any other things?
Abdominal ultrasound.
Okay, so your ultrasound was done while the labs were supposed to be coming back. It showed a pylorus that is 20 millimeters long with a wall thickness of 5 millimeters. And they could see that there are gastric contents that do not pass through the pylorus. What's the next step of your plan?
Okay. So the ultrasound and the history confirms that it's a hypertrophic pyloric stenosis. My patient is very dehydrated with electrolyte imbalance. So my first step is to give bolus. I will do normal saline 20 cc's per kg bolus and start him on IV fluids, 1.5 times maintenance of D5 half with 20 of potassium.
Okay, so you sort your fluids. What do you want to do with the patient, and do you want to recheck your electrolytes ever?
Yes, I'm going to admit him to the pediatric general surgery service. Given the electrolyte imbalance, I will recheck his labs in 6 to 8 hours and make sure that he is having adequate urine output during my resuscitation. And if not, I will repeat normal saline bolus.
Okay, so you repeat your electrolytes now. Your sodium is 132, potassium's up to 3.2, your chloride is 95, and bicarb is 32. And mom is asking you if it's time for surgery.
So with those electrolyte values, I don't believe it's time for surgery yet. I would like his chloride to be above 100 and his bicarb to be less than 30 to have safe anesthesia. So I will continue to resuscitate prior to surgery.
Okay,
And
what you said, go ahead, sorry. I cut
and
you off.
repeat values again in 6 to 8 hours. Make sure that those numbers are getting better prior to surgery.
You mentioned that you wanted to have safe anesthesia. What do you mean by that with those values that you had?
So for our pyloric stenosis patients that have metabolic alkalosis, they can have postoperative apnea because they tend to retain CO2 secondary to the metabolic alkalosis. So I have to make sure that the bicarb is less than 30 prior to going to the operating room.
Okay, so you recheck your labs now, and your chloride's up to 102, your bicarb's 28. You call anesthesia, and they say, okay, we're happy to go ahead and do this operation. What do you want to do?
So I will proceed to the operating room to perform pyloromyotomy.
And please describe the steps of that operation briefly.
Okay. I will be doing this procedure laparoscopically. I will gain entry into the abdomen through the umbilicus. I will have a total of 3 ports. I will measure out or identify the edges of the pylorus and score the serosa with electrocautery. I will bluntly dissect, separate the pylorus muscle down to the mucosa, and ensure that each leaflet is able to move independently. And lastly, I will check for any signs of leak and perforation prior to finishing the operation.
Okay, so when you're doing your operation, you're doing the spread, and all of a sudden you see some bubbles and green liquid coming from the duodenal end of your myotomy. What do you want to do?
At this point, I'm concerned that I have gotten a little too deep and caused perforation. So I will repair this with interrupted 3O silks and put an omental patch over it.
Okay, so let's say now go back to your operation. Say it went well, there was no leak, and you've started feeds on the patient, and you're 3 days after surgery, and the patient's vomiting.
Okay, and he has been continuously vomiting and not being able to tolerate feeds.
He's vomiting about every other time he feeds for the past 3 days. It's kind of frustrating for everybody.
Okay, so emesis after pyloromyotomy can happen. However, if he continues not to tolerate feeds, then I'm concerned that my pyloromyotomy might be incomplete. And if he continues to not tolerate feeds, then I have to take him back to the operating room to ensure that there is that I have performed adequate pyloromyotomy.
Is there a study you could perform before going back to the operating room?
I can repeat an abdominal ultrasound.
Okay, great, thank you. Okay, I think that for your feedback, I think you did a good job with going through the case in a pretty quick manner. I would say that you were vague in what you wanted a couple of times, so I would counsel you to try to ask for what you're going to order. So to make it quick, you said, I want some labs. Okay, which labs do you want? I'm not going to assume as the examiner that you know which labs. I'm not going to give it to you until you ask me. And so I would counsel you to be specific on the labs, the studies, what your focused exam is. When you ask for those things, then the examiner can give you those right to you. They may give you everything without you asking for it, but it's better to be specific, because then it also tells the examiner what you're thinking. I did like how you gave me your differential diagnosis. I thought with the operation, you could even make it a little bit more succinct. You could have taken out a couple of sentences to it as well. But in general, I thought you did a good job with that. And then the final answer was a upper GI study. So your ultrasound is going to still look thickened afterwards. So you're not going to be able to see much difference in ultrasound, but an upper GI study will show you if the contrast goes through in order to see if you've got an incomplete myotomy. There you go. Great. Thanks. Good work.
Awesome, thank you. We'll be moving now to the endocrine surgery scenario. So for that, we will have Dr. Sophie Dream from MCW do the case. Let me see. Am I missing? I'm missing here who you're doing the case with, Dr.
George
Dream.
Taylor.
Dr. George Taylor, yes.
Dr. George Taylor, sorry about that.
Alright.
Good luck.
So George, you have or Dr. Taylor, you have a 50-year-old female who's sent to you for consideration of primary hyperparathyroidism. Her serum calcium level is 12. Her parathyroid hormone level is elevated. She has a history of kidney stones 2 years prior and osteoporosis on her most recent DEXA scan, and no significant past surgical or family history. And she doesn't take any medications. What do you want to do?
Okay, well, from that information, I'm already thinking that she does have indications for parathyroidectomy. However, I would like to explore a little bit more of her current symptoms, focusing mainly on symptoms of hypercalcemia. You mentioned kidney stones and osteoporosis, any neuropsychiatric symptoms or GI symptoms.
Yeah, so she occasionally has a little bit of reflux, but she's not sure if she's just had some recent weight gain and her doctor told her it might be that, but she's not sure. She doesn't take anything for it. And then she does feel tired pretty often. Like she started in the last maybe year or so taking a nap in the afternoon where she wasn't before.
Okay. At this point, and you said no family or surgical history, no medications.
Yeah, no family history. That seemed worrisome as far as she could tell, and then no medications.
I'd move on to physical exam, especially of her neck.
Yeah, so she physical exam pretty unremarkable. There's no like thyroid nodules or lymphadenopathy.
Okay. At this point, I'd like to get some labs and imaging. I'd like to get a BMP, given her history of kidney stones, a vitamin D level, 24-hour urine calcium, and I'll repeat the PTH as well.
Okay. So your vitamin D level is a little bit low. It's like 20, 21. She is not on a vitamin D supplement right now. BMP is pretty normal. GFR is less than 60, or sorry, is 50. And then she has a 24-hour urine that shows a urinary calcium of 400, which is a little high.
And no family history of malignancy.
No.
At this point, I'd like to proceed with a focused thyroid parathyroid ultrasound.
Okay, so you do an ultrasound and it shows 1 centimeter TIRADS 2 thyroid nodule on the right side, and then a parathyroid adenoma on that same side. And CT scan doesn't really show the same parathyroid adenoma, but it's a similar, you see that thing in the thyroid.
Okay. Given the size and the suspicious findings, low suspicion of the TIRADS nodule on the right side, I would like to offer her a focused parathyroidectomy. I would offer her concomitant lobectomy, although, like I said, with the TIRADS 2 nodule, the concern for malignancy in my mind is low.
Yeah. So she says that she's not really worried about the thyroid nodule if you're not worried about it. So she's okay with doing whatever you want.
Okay, and then I proceed to the OR with a focused right-sided parathyroidectomy.
Okay, so how would you, can you describe how you do approach your parathyroidectomy?
I would position the patient supine with the neck extended slightly, using a shoulder roll. I would draw an PTH for baseline before proceeding with intubation and any neck manipulation. Then I tuck the arms and would proceed with the collar incision, raise up platysmal flaps and incise the median raphe to lateralize the strap muscles, dissecting under the strap muscles on the right side, looking for either the middle thyroid vein or the recurrent laryngeal nerve to identify the known location of the right parathyroid glands.
Okay, so you find that right parathyroid adenoma, and the right, it's a right superior, and then the right inferior gland looks pretty normal. So you do that one. How do you know that you're done with your resection?
Right. Sorry,
You take out the bigger right one, and you have that right lower one.
right. I should have mentioned I would also use a recurrent laryngeal nerve monitor capable ET too. I would then draw serial 5-minute PTH levels from the patient, given either adequate IV access or a stick in the IJ in the field. And then I would anticipate a drop of 50% from baseline to know that I have had a biochemical success in the operation.
And so you draw those hormone levels and the PTH doesn't drop.
Okay.
You started out at parathyroid hormone level of 120 and now you're like at 110.
Okay. At this point, I'm concerned that the patient either has multi-gland disease. So I would first identify the ipsilateral inferior gland. If it looked grossly abnormal, I would resect that as well. And then begin drawing serial 5-minute PTH levels again. While I wait for those to result, I would explore the contralateral side, looking for, again, either grossly abnormal glands or at least identifying 2 normal glands on the left side.
Yeah. Okay. So you end up leaving that one lower gland in because you feel like it just looks so normal. End up looking at the other side and then see that the contralateral, the left superior looks pretty big, and that right inferior looks pretty normal, the same way that left inferior looks pretty normal too.
Okay, yeah, then I would excise the abnormal looking gland on the contralateral side, again, drawing serial.
Yeah, then levels drop, you look great. So then what do you want to do from here for her?
At that point, I would mark the remaining parathyroid glands with clips, close the strap muscles, close platysma, and close skin.
So say that you had gone back in the ultrasound and that thyroid nodule had been like a 2-centimeter TI-RADS 4 thyroid nodule.
Yeah, so prior to proceeding to the operating room, would have performed an FNA on the thyroid nodule to see if it met suspicious criteria for needing full tissue biopsy and need of a concomitant lobectomy.
So if you do you do that, you get an FNA. The FNA result shows Bethesda 5 cytology.
Yeah, so then I would have proceeded with a right thyroid lobectomy as well as a parathyroidectomy.
Okay. So once that thyroid then has come out, you take you to the lobe, you talk to that patient about, okay, this is indeterminate. She agrees to having the diagnostic lobectomy. On final pathology, it's a 2-centimeter papillary thyroid cancer.
Yeah, so she's 50, in follow-up and talk to her about her pathologic results and discuss completion thyroidectomy given that it is a cancer.
Okay. She says, do I have to get that other side out?
We could monitor the other side with serial ultrasound examinations, but I would recommend strongly completion of thyroidectomy.
All right, great job. So my caveats, teaching points. I feel like the one thing I always tell people, I think this is what I'm supposed to do next, right? Just all right. I always tell people for parathyroid and thyroid disease to always get an ultrasound and a CT scan. The CT scan helps you look for ectopic glands. So if it's going to be something behind the esophagus or trachea or upper mediastinum, like the thymus, they kind of have to tell you if there's something in those spaces. So, and then the ultrasound helps you look for concomitant thyroid nodules, so you're not running across in the operating room for a thyroid cancer. So I always say get both of those. And if they can't do contrast, then a nuclear medicine scan and an ultrasound. With parathyroid disease in the OR, if they say there's a normal gland, it's always tempting. And even in the OR in real life, it's tempting to take out the thing that you saw to see if the levels drop. But if it looks normal, we always leave it on. You can have double adenomas. You can have 4 gland disease and a single adenoma. So if it looks normal, you want to leave it alone until you've kind of looked at everything. So I think that's also the other thing about it. what else? With parathyroid, with thyroid cancers, we're in this era of lobe versus total. So a lot of times it's a lot of patient counseling and whether or not the patient wants a lobe versus total. So it is acceptable for low risk thyroid cancer where it's less than 4 centimeters and it doesn't have like lymph node involvement, lymphovascular invasion, not multinodular, to do a lobectomy and have patients surveilled over time. So I think it's really important that we don't have to be doing totals in all these people. But yeah, I think otherwise George did great.
Okay, well, thank you very much, Dr. Dream and Dr. Taylor, for that scenario. We'll move on next to our next scenario, which will be in foregut and MIS. Dr. Mittal will be our examiner, and Dr. Sean McGuire will be our examinee. And then just briefly, if anyone has any additional questions in the attendees, you can put it in our Q&A, and after all of our scenarios are over, we'll have an opportunity to address them. All right, take it away. Dr. Mittal?
Sorry, I can't start my video. I don't know how this guys started from there, or how do you guys do it?
Bev might be able to help you out, but while she's trying that,
Sean
maybe...
there?
Yes,
Yeah,
Sean is there.
you can go ahead too. I can hear you. So
Yeah, you don't need to see me, man. It's okay. Good to see you. Good. So you are the general surgeon on call, and you get a call from the emergency room saying that there is a 62-year-old guy who comes to the emergency room with complaining of chest pain and fevers, and he had an endoscopy procedure at 8 o'clock in the morning. And and he just comes with complaining of fevers and pain going to the back. The chest X-ray shows that there is some air and fluid onto the left chest. What are you gonna do?
I mean, the first question I would want to ask is just if I'm on the phone with the ER, is just to know the patient's vital signs as well as their if they're showing any evidence of respiratory distress.
Well, they feel short of breath, but they're not requiring any oxygen right now, and they're tachycardic at about 125 per minute, but the blood pressure is fine at about 130 by 75.
Okay.
Temperature is 38.5.
Okay. So my initial concern, and I think the most concerning thing, would be an esophageal perforation after his upper endoscopy. But I would want to proceed to the emergency room and start by obtaining a complete history and physical exam. And I would want my history to focus on, especially the indication for his EGD, as well as if I was able to get my hand on an operative report from the EGD.
So the reason to do an endoscopy was dysphagia, that I had trouble swallowing. However, the operative report has not been signed yet, so you can't get access to it.
Okay. And then on physical exam, I would want to know, in terms of breath sounds and overall abdominal exam as well.
The gentleman looks kind of in distress, but otherwise he is stable. His decreased air entry on the left side, the abdomen is completely benign, and there is some crepitus in the neck.
Okay. So I would essentially start now to ensure that he has adequate IV access. I would want to make sure that he had at least 2 IVs. I would also give him a 1 liter crystalloid bolus, and I would start him on broad spectrum antibiotics, including Zosyn as well as antifungal coverage. I would make sure that he was NPO, and then I would also send labs, which would include a CBC, BMP, lactate, and I would get an EKG.
So the labs come back, the white count is elevated at 16, the BMP is relatively normal, the EKG is normal. All the rest of the labs are normal.
Okay. My concern remains elevated for esophageal perforation and iatrogenic esophageal perforation. So I would plan to do a contrast esophagram with water-soluble contrast.
So it shows that there is free contrast flow into the left pleural space.
Okay. Then I would advise the patient that I was worried about an esophageal perforation and that I would plan to proceed to the operating room for operative repair.
Okay. Anything else you want to know beforehand?
I think I would kind of round out some of my history, ensure that he doesn't have any incredibly significant medical history or past surgical history.
And okay, and what will you consent him for?
So I would consent him for a left thoracotomy with repair of esophageal perforation and chest tube placement. I would also advise the patient that depending on the intraoperative findings and the viability of the esophagus, that we may have to proceed with essentially either a diversion or esophageal exclusion. But I would say that my plan was to do a thoracotomy and esophageal perforation repair.
Okay. So you go to the operating room, just tell me the steps, what you're gonna do.
Sure. So I'd begin with a left thoracotomy. I would decontaminate the field and remove any extravasated food or anything that he had. I would mobilize and isolate the esophagus. I would identify the area of the perforation, and then I would extend the injury that I identified in the muscle to fully visualize the extent of the mucosal injury. I would then repair the injury in 2 layers, and then I would place 2 chest tubes and close the chest.
Okay. When you were in the operating room, you felt a mass in the distal esophagus where the leak was coming from. It looks like a malignant appearing mass.
Okay. In that case, if I felt it externally, then I would proceed with performing an upper endoscopy myself to evaluate the mass.
It looks like a fungating tumor.
Okay. In that case, I would proceed with I think I would not be able to probably safely close the injury over the area where the mass was, and so I would plan to perform an esophagectomy.
And what would you do?
So I would be able to use my same approach. I would want to assess the stability of the patient at that time, including his intraoperative stability and his hemodynamic status at that time.
He's hemodynamically stable. He's well resuscitated. No signs of sepsis. His heart rate has come down since you resuscitated the IV fluids, and that's where he is.
Okay. In that case, I would need to more fully mobilize the esophagus and to be able to, fully identify the area of the mass and get enough mobilization that I was going to be able to resect the area that I was concerned about. And then
it's a distal esophageal mass right above the hiatus.
Right above the hiatus. Okay. Then I would be able to transect the esophagus, and I would plan to perform. I would need to essentially also do a midline laparotomy so that I was able to. I would perform an esophageal jejunal anastomosis. I was able to that, yeah, so.
When you get to the abdomen, you're not able to get the jejunum up onto the esophagus. It's too high.
The esophagus is too high in the.
Yeah, the way to resected it is almost at the inferior pulmonary vein or higher. You're in the abdomen. So you close the chest and go to the abdomen?
So I would resect the esophagus, and then I would mobilize, making sure that I had enough mobilization on the esophagus, but and then I guess the other option would be I could perform an EG anastomosis using a circular stapler, but.
Okay, that's fine. I threw a curveball. So I think the patient went to the recovery room and then went to the ICU. Then about day 5, there is some green bile coming out of the chest tube.
Okay. Then I would plan to repeat a contrast esophagram at that point.
There is a leak from the esophagogastrostomy that you made into the left chest.
Okay. In that case, I would consider, if possible, I would talk with GI colleagues to see if they were able to stent across that.
The
I would
GI
also
left.
continue the patient on antibiotics, and I would also start the patient on TPN at that time.
Okay, I think about our time are done. Sean, great. I knew I wanted to throw you a curveball right in the middle of it. And I'll just, go back and say that, yes, the gastroenterologist is not available, but you can glean a lot of information what the diagnosis could be by asking the patient for what the indication which you did, like dysphagia. But then you can have asked that how long-standing it is. Have you lost weight? Is it solid or only liquids? Trying to distinguish whether it's more likely to be malignant or not. And then you can simply ask the patient that did the doctor tell you anything about or any pictures that they gave you? Okay. And then I think your decision to do a resection is the right one. And it's just that when you're in the left chest that you have to do, generally you'll end up doing an esophagogastrostomy through a two-stage procedure, which you do. I think I would have said that you also want to put a feeding tube at the time of surgery.
Okay.
All major operations, you want to put a feeding tube in. And I think otherwise, I think you worked up the patient, but just don't go down the line that it's going to be a benign disease, which you did. And that would be my biggest critique. And then when you're describing the procedure, I just think it'll be very easy and short term to mention in the left side up lateral decubitus position. And then at least in the chest, it matters that where the incision would be, that what intercostal space you would go in.
Okay.
I would just quickly say that, put it in the left side up lateral decubitus position, get single lung isolation. It'll be good to, mention that so they know that you're thinking about it with double lumen intubation. And then that you went into the whatever intercostal space you decide, which in this case would be the 8th intercostal space. And then first I palpate to make sure there is no mass. And then I would generally just always do an intraoperative endoscopy to check your leak, even if you were repairing it. So if you have access to that. But otherwise, it was a tough case. I just want to make sure we end on a big downer to make sure that you guys all keep studying, So good.
Thank you. Appreciate it.
Yeah.
Okay, let's go to our last scenario, which will be the vascular surgery scenario. For that, we have Dr. Elizabeth George from Stanford University and one of our vascular integrated vascular surgery residents, Dr. Sabina Sarondo. I'll leave it up to both of you.
Great, thank you for joining us today, Dr. Sarondo. I'll go ahead and start with the scenario that I've shown here. In our vascular boards, you start with a stem like this. 82-year-old male with a history of hypertension, prior MI, who had a PCI 8 years ago and heart palpitation, presents to the ED with 12 hours of progressively worsening abdominal pain. Rainbow labs at the door show a white count of 16, lactate of 5, creatinine of 2, and INR of 1.2. How would you like to proceed?
So first I'd like to proceed with a full history. Has he ever had pain like this before? The quality of symptoms, onset of pain, and then get vitals and the physical exam.
Vital signs shows the patient is tachycardic and somewhat tachypnic. Abdominal pain is severe, excruciating, and pain started about 8 hours ago, and now over the past 2 hours has just become absolutely excruciating.
Okay. In that case, he has a history of AFib, and is he on anticoagulation or holding that for any reason?
No, he doesn't. He's never been diagnosed with atrial fibrillation.
Okay. So at this case, I have the labs. So I would ask the ED to start some intravenous fluids and get some imaging, particularly a CTA, abdomen, pelvis. I am concerned for some sort of abdominal pathology, potentially acute mesenteric ischemia, other things, including like a perforated viscus.
Okay. Ultimately, the patient also got an EKG in the ED too, which does show that he's in atrial fibrillation. So he's not anticoagulated for that. He did not know he was in atrial fibrillation. What imaging would you like to get?
I'd like a CTA, abdomen, pelvis.
Obtained a CT. And it shows this. Please describe what you're seeing.
So I see aortic with some mild calcification, some mild disease. And then if you look closely at the SMA, it appears that there seems to be a thrombus burden just before the takeoff of what I believe is the middle colic artery.
So what are you concerned about, and what do you think the etiology is?
So at this point, given that this patient is in atrial fibrillation, did not know he was an AFib without anticoagulation, I'm concerned for an embolic event to the SMA causing acute mesenteric ischemia. Based on his labs and vitals and an abdominal exam, I'm also concerned for bowel viability at this point. So I would plan to take the patient to the OR, and in the meantime, I'd start a full dose heparin drip, IV antibiotics and fluids.
What would you bolus him?
For heparin, I would give a full dose. So it'd be 80 kgs, 80 units per kgs for the bolus, and then continuing at a rate of 18 kilograms per hour.
18 units per kilogram per hour. Perfect. And then what would be your operative plan?
So I would take the patient to the operating room, and prior also get my general surgery colleagues involved to assess the bowel. So I'd start with an exploratory laparotomy. If there was any evidence of frankly necrotic bowel, I would have them resect that first and leave the patient in discontinuity prior to doing my portion of the case.
And then what is your part of the case?
So once they have done their portion, I would perform an SMA embolectomy. So I would lift the omentum and the transverse colon cephalad, mobilize the small intestine to the patient's right, and then find the root of the mesentery. Typically, sometimes there is a pulse. Sometimes you can use other things like Doppler to find a pulse, or just feel for a cord-like structure. Open up the peritoneum overlying the SMA, get proximal and distal control. And then systemically heparinize the patient with weight-based dosing 100 units per kilogram, and then redose appropriately throughout the case with a goal of ACT above 250. Once I have control and the patient is heparinized, I would perform a transverse arteriotomy and perform a thromboembolectomy using a Fogarty balloon catheter.
What size Fogarty catheter would you use?
Typically, depending on the size of the vessel, I would start with a 3 to 4 French. If the vessel was diminutive or I needed distal embolectomy, I would downsize to a 2 or 3. And then I would perform embolectomy until I was free of clot burden.
Mm-hmm. What if the SMA is quite small? How would that change your approach?
If the SMA is diminutive or burdened with plaque, at that point I would not do a transverse arteriotomy. I would actually make a longitudinal one and then repair the artery with a bovine patch angioplasty to expand the size of the vessel.
Okay. How do you know if your thromboembolectomy is adequate?
So you typically want 1 to 2 passes free of clot burden. So once you have the first one, typically perform it 1 to 2 times more to ensure that there's no residual clot. Afterwards, you can also assess forward and backward bleeding. And then after you close your arteriotomy, whether that's closing it primarily if it's transverse versus bovine patch angioplasty, check distal signals in the mesentery as well with a Doppler.
Good. So patient's left in discontinuity, then what's your plan?
After we complete the case, I would then take the patient in discontinuity with a temporary abdominal closure to the ICU, monitor for 24 to 48 hours, and then bring the patient back to the OR for a second look.
What if on your second look, the bowel appears slightly dusky and you're unsure about its viability?
If the bowel appears dusky, there's a couple of things you can do. So you can potentially look at the bowel using Wood's lamp to see the bowel perfusion and see if it's viable.
Yeah. Okay, changing it up a little bit. Now the patient is well known to the vascular surgery service, high burden of atherosclerotic disease, and presents in a similar way to the emergency department with signs and symptoms of acute mesenteric ischemia, no history of atrial fibrillation. How would you approach this differently?
So if the patient had a history, was well known to our service, probably some component of chronic mesenteric ischemia. So I would be more concerned for an acute unchronic event. So more of a ischemia secondary to thrombosis. Typically, this is in the setting where it's more proximal in the SMA, and it's also involved with heavy plaque burden, which is usually not amenable to an embolectomy alone. So in this situation, I would again still explore the bowel and
if I had the ability to do so in a hybrid room, I would perform a ROMS procedure, which is a retrograde open mesenteric stenting.
What if it's what if that's not available? What if there's no endovascular capabilities?
If that's not available, then I would most likely proceed with a retrograde bypass. With a lazy C configuration. So if the right common iliac was relatively free of disease burden, I would use a conduit of a 6 to 8 millimeter PTFE and do a retrograde bypass.
Why wouldn't you use vein?
So vein is a lot more compressible in the abdomen. So I would be worried about patency with vein, and PTFE is more resistant to that sort of kinking and pressure.
Okay. We'll go ahead and stop there. Nicely done. We'll stop there. Let me just go ahead and share my screen one more time. I have one more tips and tricks. Sabina, nicely done. Don't forget to give antibiotics as well. The heparin, I know heparin is always a big thing that we're concerned about, but I want to make sure that we give antibiotics as well. For here, just kind of last little tips and tricks. I know it may have been a while for a lot of you to have had some vascular exposure. So quick hits. So always heparinize. Think about heparin. Don't forget to give heparin. That's one of the biggest kind of means or mechanisms of failure on vascular questions from asking those who give the exam. Basic principles apply. Proximal distal control. There are many different ways to obtain proximal distal control when you get called for kind of either traumatic or iatrogenic bleeding. So you use vascular clamps. You can use PTA. You can use wire over the wire balloons. You can also use Fogarty balloons with a three-way stopcock to obtain proximal or distal control. If you're in a dirty setting, a trauma or with frank bowel spillage, think about using autologous conduit. In that last scenario, I didn't say that there was kind of necessarily different contamination, so it's okay to use PTFE in that setting. But if it's a dirty field, definitely use autologous conduit, GSV, gonadal vein, femoral vein. Boa and pericardium is considered clean in this. Is also a good conduit, and you could tubularize it actually using just an NOGIA staple or just staple across. Then you can trim it to length. Lower extremity bypass, kind of general principles for kind of peripheral arterial disease or in a trauma setting. Three principles that you need to think of. Where's your inflow going to be? What's your outflow going to be? And then what is your conduit that you're going to use? So those are kind of the three things to think about as you're planning for lower extremity bypasses. For hemodialysis access, which I know you guys are asked about, difference between AV fistulas versus AV graft is important to know, as well as think about kind of Steele syndrome, different ways of managing Steele syndrome. So using a RUDI, or revascularization using distal inflow, versus a drill procedure, distal revascularization and interval ligation, kind of knowing the difference of those. Kind of pick one to learn and then go and be able to describe that for your exam, and kind of those 5 steps as folks have been talking about. For abdominal aortic aneurysms, kind of the EVAR versus open debate. What is the size criteria for elective repair? It's 5 centimeters for women and 5.5 centimeters for men. And then in a ruptured AAA scenario, just go for supraceliac control first, and then you figure the rest of things out. For carotids, which also are on your exam, kind of what the common nerve injuries are, vagus, hypoglossal, as well as if there's any neurodeficits afterwards, default is reopen. It's a technical error to have proven otherwise. The patient wakes up with neurodeficits. And things that will make a vascular surgeon sort of just like cringe is when someone says Doppler pulses. They are Doppler signals or palpable pulses, but not Doppler pulses. That's one way to kind of upset your examiner. And then last but not least, heparinize. Don't forget to heparinize. Thanks so much for having us.
All right, thank you everyone for participating in this mock oral scenario. If anyone has any questions from the general audience, please feel free to drop it in the Q&A. Thank you again. I think we had a really great breadth and variety of topics, of scenarios. Special thank you to our faculty examiners. There was some really good pearls, I think, not only topic specific, but general approach specific. I think for any junior residents out there, hopefully this is a good intro to that. And then for any senior residents out there, hopefully you were able to get some good tips and tricks for the certifying exam. Oral boards, I think at this point we all know, is a very different kind of testing beast. It's not like any other standardized tests that we have taken in our medical career. It involves a whole different testing approach in terms of reaction, thought process, and being able to think quickly on your feet while also still thinking thoroughly and efficiently. It doesn't look like I have any other questions in the queue bank. Carlos, I don't know if you had any other final remarks.
I honestly think you hit it all. I think, like you said, for the junior trainees, this is an intro of what to like prepare for. And I think for the more senior ones, I think that the most important thing, and this is something that when we practice at our institution, just don't give more than you need to. Just stay on point and just be systematic. And I think a lot of the same advices that we're given, just summarize and just simplify things and let people ask you things.
I think just
It was a good session.
the one thing that I feel like really helped to calm me down for this was like when I realized that I didn't have to do like an operation for every scenario, and I just had to talk through like the basic tenets of an operation. I feel like that was like really intimidating to me because I was like, when my mind thought I was doing all these operations, and you don't have to do that. You're not actually doing the case. You're just talking through. Like if you had to tell someone what the operation is in 7 minutes, what you do in clinic all day. So
Yeah, and I think that was a common theme we saw in our feedback for each scenario. As I think as a surgery resident, it's very easy for us to get caught up in the details of the surgery. We want to sort of mentally go through the surgery, but for the purposes of boards, it's a 7-minute scenario or less, and so just really giving the general key concepts and proving to your examiner that you understand the general the key steps of the operation or the key factors of the operation. We do have one question in the Q&A of what available resources to study and practice that have been found useful and helpful. I know that there are courses and as well as podcasts that go through sort of similar mock oral scenarios like this, but I have found that I think the most well-reviewed study approach is actually just practice with your co-residents, with your classmates, and then with other faculty at your institution. I know here we have a lot of faculty who are very receptive to any resident reaching out to them and asking, hey, can I practice an oral board scenario with you? And from what I've heard from other senior residents, that has been the biggest help to them. Carlos, I don't know if you had any other recommendations and any other answers from the rest of our panelists.
No, I think yes. Usually, I think people tend to do groups, like you and your co-chiefs when you graduate, like they do groups and then you study together, do scenarios together. There's the Osler kind of course. It's a popular one, and I think one that is gaining a lot of popularity is the Behind the Knife series. I heard it's pretty good. I haven't heard it or used it, but I've heard it's pretty good. And then the books that you use during residency, your notes, and then the question banks help, at least for info.
I always felt like my textbooks from residency, my notes from residency were too detailed. I like used the Dimick book, like has like almost any required scenario in it. So I think that Dimick book was really great to just like methodically go through it. The Neff book was just good for adding in extra scenarios. And then the ABS has that Excel spreadsheet of what they can ask you on oral boards. And so I think going through that methodically, making sure you've hit, I had that Excel spreadsheet as I was studying and just made sure that I was going through everything that was green, because those they can ask you. The things that are red, the advanced things, they can't ask you to do on your oral board. So it helps narrow it down so you're not just going out into the weeds. And then just like make sure you're just methodically filling in scenarios and how you talk through them that way.
And then we do have one last question to clarify on, I think it was the foregut or MIS scenario with Dr. Mittal about whether the board answer would be to perform an oncologic resection for that scenario. Dr. Mittal unfortunately had to log off. If any of the other faculty wanted to chime in on this answer. I think my approach probably would have been to or I would be also wonder if a safe approach would be to do a diverting cervical esophagostomy and save the oncologic resection for a later time. But I would be curious about this if anyone has that answer. If not, I can reach out to Dr. Mattel on email afterwards too. Okay, so for the attendee for that, I will reach out to Dr. Mattel and see if I can include that in the resources on the webinar webpage, and I'll send that to his answer to Bev, and Bev can maybe help post that on the webpage as well.
I do think you're right, Rachel. I'm a little bit removed from it at this point.
Yeah, it was a hard curveball.
Yeah. But I also, again, the point of a lot of those curveballs means you've passed the critical portion of the scenario. So that curveball, even if you get it wrong, they can't fault you for it. An esophageal perforation is something you need to talk to, and esophagectomy is not something that's on the oral board. So I think that's like a really important distinction is they can throw you that curveball, but if you're not going to fail for it, it's just important to have that running list in your mind so that you're not getting in your head of like, oh my God, I couldn't do an esophagectomy, but you actually can't fail for that.
And I think the other thing is they're not going to fail you for being safe, which
Yeah.
a diversion, my computer was acting up during that, so I don't know the big name, but if it says something, someone scratching on extremis, like doing the safe answer, which will be diverting with a split fistula, is probably okay.
Yeah.
Okay. If any last or final comments from our panelists?
I was just going to mention that another prep course that wasn't mentioned earlier is also Odyssey, which I was looking up and is still around. The benefit of Odyssey is I think OSER tests you right before the board, so it's very close. And Odyssey is usually held about a month before your whatever exam you pick. So there is a day of just like didactic review and common scenarios, and then they test you and they kind of pick out things even down to like your fidgets, the way you say things, the way you talk, all the way to content. And it's given to you a month in advance. So you have a month from all this feedback to kind of work on it. So I took that. I found it very beneficial. Also, you meet a lot of people in that class, and then you find partners to practice with. So it's just another option that I think people don't know about as well, but it's a very good prep course.
All right. Thank you very much, everyone. Thank you for your time. We've gone a little bit over time, so I apologize for that, but thank you again. And good luck, everyone, on the certifying exams if you're taking it later this year. So
thank you to you and Carlos for organizing all of us.
Thank you.
Thanks so much. I know vascular